Hello and welcome to this video on foot and ankle anatomy and biomechanics. And in this video, I want to review this application is called Essential Anatomy, and we're going to go over foot and ankle skeletal anatomy, muscular anatomy, probably talk about the nerves a little bit, and then we'll also review the connective tissue, so other soft tissue things that help connect to the muscles, to the bones, or the tendons and the ligaments and that sort of thing. So when we talk about lower extremity foot and ankle anatomy and biomechanics, we need to be aware of what bones connect to what and how those things influence the biomechanics. So with the foot and ankle, we have our tibia and fibula. So that's the lower leg portion of it that connects with our talus. And as you can see, that's the bone that makes up the ankle mortise. And so talocrural joint is really responsible for plantar flexion and dorsiflexion of the foot. As you'll see in a little bit with the connective tissue part, as the foot goes up into dorsiflexion, this area through here where the tibia and fibula meet, if that gets overstretched or overgapped, because as the foot goes into dorsiflexion, it opens up that space. And if that happens too aggressively, that can be a high ankle sprain. So this joint here, the talocrural joint, is responsible for mainly plantar flexion and dorsiflexion. In school, we learn about the different shapes of joints, and you can see that this joint is so complex. It has a lot of different, if I isolate this bone here, you can see all the different concavities and convexities as they attach with different parts of the foot. So I don't care too much, but I want to know what happens broadly through an area of joints. So as the talus meets with the navicular bone, and as that translates into the cuneiform, so medial, intermediate, and lateral cuneiform, as those three things happen, that's what needs, as your foot meets the ground, that's where pronation and then supination needs to happen. And so that is largely the structure of the arch as well. And that's why these connections are important. So when I'm doing hands-on work with people, first I'll look at the motion in the talocrural joint, and then I will check motion at the subtalar joint. And so that's how our calcaneus meets the talus here. And there's great videos. I'll post one in the links also on open and closed chain motion at the talocrural joint and subtalar joint. And that kind of shows a biomechanical analysis of how those work. But understanding the principles of how these connect is really important. So we have the talus, the calcaneus. As I go to the inside of the foot, here's the talus again, and you can see how that meets with the navicular bone, which is sort of our mid portion of our arch. So here's the arch as it goes into compression, and then the spring action of it, it's that navicular that drops down. Now, if that happens uncontrollably, that navicular bone will collapse into pronation. And uncontrolled pronation is a problem because, as you can imagine, if I'm going to bring this down a little bit, if I go into pronation, my foot drops into tibial internal rotation or femoral internal rotation, and that creates a whole sequelae of, let's say, just different stresses that need to go up the lower leg. So we have navicular bone, our three cuneiforms, medial, intermediate, and lateral. And then that connects with what's this bone right here. So we have our calcaneus and then the cuboid bone. And we often hear about the cuboid getting stuck or lacking mobility, but that's largely going to be dictated on the position of the foot. So if the foot is always resting in pronation, you can see how it would sort of expose that joint while you're walking. And if it's always in supination, so let's say you walk here and your foot goes only on the outside of the foot, so from the calcaneus cuboid into the fifth metatarsal, then we're going to see a different problem of too much lateral stress through the foot. Because as we walk, the foot needs to start in a little bit of supination. So as your foot matches the ground, you supinate, and then you roll into pronation, and then you go back into supination. And that allows you to hit the ground rigidly so you have support, adapt to the ground, and then again, push off from more of a rigid foot position. So we need those mechanics to happen. And if this mid part of the foot can't unlock, let's say there's too much rigidity or you're too much in a high arch locked position, then we're not going to get that molding to the ground to then be able to push off again. And that becomes a problem. And people who are too high arched are often, let's say they have too much supination that draws their lower leg into external rotation. It sort of works its way up the chain, is creating this lateral chain tension. So back to the anatomy piece of it, we talked about how the calcaneus meets up with the cuboid, and then we have our 5 metatarsal joints here. So 5th metatarsal, 4th, 3rd, 2nd, and 1st metatarsal. Now, between the metatarsals, if I add on some of the nerves, we can see how different branches, this is the medial dorsal cutaneous nerve, which is going to be, if we follow that nerve all the way up, let's zoom in on that. That becomes the superficial fibular nerve, which then comes back to go all the way up to as being a branch of the sciatic nerve. But these each are going to undergo tension and compression with various positions in the foot. What I wanted to show you as we get back into here is that these nerves that go through the metatarsals, so let's say through the 4th and 3rd metatarsal, the most common thing that can happen if we aren't giving enough arch support there is that extra movement through the metatarsals can create a neuroma type of pain. So removing the nerves here, we have our 5th metatarsals, and then our phalanxes that work down. So 2 for the great toe, 3 for the other toes, just like the hand. And those are really important for creating other arch structure in the foot. We'll commonly see people who, let's say, so if here's my middle arch of the foot, if these are the toes down here, people will often become very flattened through the end of their foot, and that puts a lot of pressure underneath the pads of the feet right through here. And that creates a lot of joint pressure, joint strain in people. And so maintaining the different arches in the foot. So you have the long arch of the foot, and then we have a distal transverse arch. And that's the ability to, when you're walking, to maintain some almost curvature through the foot instead of it locking out like that, which is going to put more pressure through the bottom of the feet. The other compensation is that the toes will start to curl up like that if we lose arch pressure in that distal transverse arch. So that is a quick skeletal anatomy of the foot. Now let's go back to the main actions of the foot. So we just talked anatomy. Let's talk biomechanics. Flexion, extension, or plantar flexion and dorsiflexion comes from the talocrural joint, which we talked about earlier. The pronation and supination is going to come a lot more from, it's a combination movement of joints. So that comes from our subtalar joint, so where our talus and calcaneus meet, but it's also compound of what happens in these mid-tarsal joints here. So all of these joints are going to help play a significant role in how the foot can collapse into pronation and then regain support to go back into supination. The key thing here is that pronation is not better than supination, and supination is not better than pronation. They need to happen together and they need to work with each other. Different life circumstances, if I'm squatting, my foot needs to do something different than when I'm pushing off while walking. Both pronation and supination are extremely important, and based on your environment, your past movement history, past injury history, all of those things are really going to determine how much pronation and supination you have available. But it's not pronation's bad or too much supination's bad, is that we need to do both of those, and we need to be proficient through the range of those. So that's where a lot of our pronation and supination comes from. Talocrural joint, subtalar and mid-tarsal joints. And then, so that's good. And then inversion and eversion are the last 2 major movements of the hindfoot. And so with eversion, the foot is going to go usually up into dorsiflexion and eversion. And what causes that motion, if you can picture it, if you pull your foot up into eversion right now, it's going to be your perineal muscles, and then it's also going to be your anterior tib. So I'm going to add on some layers of muscle here. This program is so fascinating. That's our extensor hallucis. I'm going to add another layer on here. Extensor digitorum. One more layer. You can see the anterior tibialis is going to help pull that foot up into dorsiflexion, but then our everters are going to be more of our fibularis longus and then fibularis brevis, which is underneath that. And so those muscles are going to be the ones that pull the foot, and do it right now. Pull your foot up and out, and you can feel that front side, so the tibialis anterior, and then the everters, your perineal muscles, turn on with that. Now, eversion, and then inversion is gonna, so we have anterior tib that causes dorsiflexion eversion. For plantar flexion inversion is gonna be more of, let me take this muscle away here. We're gonna see our tibialis posterior working with our calf muscles. So tibialis posterior, as well as your gastroc and soleus complex, are going to be the biggest muscle groups that help you go down into inversion and plantar flexion. Now we're getting a little bit ahead of ourselves with all that muscle stuff. So let's go back down to the foot and ankle. We covered the bony anatomy. We've covered the different movements that happen primarily in the foot and ankle. And then lastly, I want to cover some of the connective tissue part of this. So oftentimes when people have an ankle sprain, it's going to be an outer ankle sprain, because if they injure the inner deltoid ligaments through here, then if you injure the inner parts, you're often going to break that inner ankle bone. When you injure the outer ankle ligaments, then that's where we have our standard lateral ankle sprain. So if we look at, let me hide this ligament here. We have the outer ankle ligaments are going to be our calcaneofibular ligament, anterior talofibular ligament. So the ATFL, that's the most commonly injured ligament in ankle sprains. I think it's injured in almost 70% of ankle sprains is this ligament here. And picture your mechanism of injury. If you land on your foot and it quickly goes to the side, it stretches the heck out of those ligaments there. That's going to be your ATFL ligament. Then we have our CFL, calcaneofibular ligament, and then our PTFL. So remember this as ATFL, anterior talofibular, posterior talofibular, and then CFL, which is easier to remember. It runs from your calcaneus to your fibular head. So CFL, those three ligaments make up that lateral ankle complex. And depending on how the ankle is stressed with movement, are going to determine where that injury happens. I want you to see those three ligaments as how they connect into lateral ankle sprains. But I also want you to think about this as if we add this layer back on, you can see these ligaments, but there's also this dense retinacular fiber over the top of this. So when these things get overstrained or over like a sprained ligament, we're really putting a lot of stress through a lot of these retinacular fibers as well as the underlying ligaments. It's not that that ligament is the only thing that takes on stress. All of this stuff gets quickly overstretched, and that's going to injure the soft connective tissue. So our collagen needs to return and recover there. It's going to injure some of the underlying arteries and blood vessels, because if we add in the arterial tissue, you can see how there's arteries running all through this area. But the mechanism of injury is really, when someone comes in, they say, I rolled my ankle. You say, well, how did you roll it? If it's an outer ankle sprain, it's most likely going to be those three ligaments on the outside of the foot and ankle. Now, my father-in-law was just water skiing, and he's 68 years old or so, and he had on x-ray what looked like his mechanism of injury would match a high ankle sprain. Now, he was really tender to the touch before he had any x-ray, he was really tender to the touch on this bone right here. And per the Ottawa ankle rules, when you have tenderness in the distal portion of the lower leg or any bony tenderness, then you need to send him in for an x-ray. And based on his age and traumatic mechanism of injury, all those things made me say, let's go get an image on this first before we really start treating it. And what ended up happening is he had a small avulsion fracture, but then he primarily had what looked more like a high ankle sprain. And high ankle sprain is different than a lateral ankle sprain. So we just talked about lateral here. If I pull back some of this other retinacular tissue, so hide that, I'm gonna hide this. You can see, and here's this interosseous membrane. And earlier, as we were talking about the anatomy, I said that as the ankle goes into dorsiflexion, so if you pull your ankle up into dorsiflexion there, it widens or gappens the ankle mortise. So it spreads open slightly the space between the tibia and the fibula. So as that space opens up, it's meant to handle that. It's meant to make room for that. But if it happens too aggressively, it gaps that space here, and that puts a lot of pressure through that interosseous membrane. And that's what most likely happened with my father-in-law, is that as he went into that sort of quick, aggressive mechanism of injury, it strained the retinacular tissue and the ligaments that span across this area. Now, lastly, so that's the lateral part. Here's sort of the middle part of the joint. And then, as I mentioned earlier, we have this medial ligament, or the deltoid ligament, which is on the inside of the ankle. Most likely, if an ankle sprain happens, it's going to happen to the lateral side of the foot where those outer ankle ligaments get injured. If the foot collapses too hard medially, there's so much dense connective tissue on the inside of the ankle, so much retinaculum type of tissue, which you can see here, and then the stabilizing ligaments there. Plus, the bony anatomy is much more limited that way. You see people that have a lot more a lot more inversion in the ankles available than eversion, especially like when we talk about pronation and supination. And so if you injure that on the inside, it's most likely going to create a fracture of the bone and other problems versus just a ligament sprain. So think about that when we're talking about mechanism of injury and your differential diagnosis. When to refer for an x-ray versus when do you think it's okay. For those things, I use the Ottawa foot and ankle rules to determine a radiograph versus treating conservatively. But I want you to think about the mechanism of injury, what local tissues are there and can get aggravated, and their patient presentation, how they show up that day. So we didn't talk too much about the nerves. We brought up a little bit about the Morton's neuroma. In other videos, we'll get into how the nerves might mimic plantar fasciitis and other things like that. But in this video, I wanted to give you a pretty strong overview of the skeletal anatomy. So our talus, fibula, tibia, fibula, talus, calcaneus, navicular, cuneiforms 1, 2, and 3 going across the top into the cuboid, our 5 metatarsals into our phalanxes. And then we talked briefly about some muscular anatomy and then also the connective tissue. So I hope this provides some framework around how you view foot and ankle, and then how all those structures connect to create cohesive movement in the lower leg.